Good evening, all. I am Dr. Sheetal from Rainbow Children's Hospital, and today the topic of presentation is choice of inotropes and evidence-based management and recent updates. So, I'd like to know whether I am visible and audible. Will you please put in the chat box? So we'll start. Basically, what is the what is the current approach to the management of hypertension? So what we see is uh, So what is the intervention normally? Whenever any baby is in hypotension, the first thing is the baby is given some volume, fluid bolus followed by dopamine is started, and then we observe the baby for the response in the mean blood pressures. So this is the current approach which is followed in maximum of the NICUs. Obviously, there have been refinements, but this is the approach which was kind of empirically followed for many years. But this approach lacks no voice coming. Hello. Okay. So shall I continue, please? Yeah. So there is lack of evidence for the same. And so today we are going to discuss uh, the my topic in the overview is that defining normal blood pressures, defining hypotension and shock, evidence for antihypotensives, restrictive versus conventional approach. Then what is the flow-based approach, inotropes, pathophysiology based approach, and disease specific approach. So, and the summary. So, normal physiology of blood pressure is that the blood pressure, we know that it increases with the gestational age, with the birth weight, and the postnatal age, and it is influenced by gender. So, there is a physiological fall in blood pressure in the first postnatal hours of life, and it increases over 3 days. So, we have to remember that there is a physiological fall in the BP in first few hours of life. And how do we define normal BP and hypertension? So, basically, when we want to start treatment, first we should know what are we aiming at, what is the normal and what is the low. So one of the common definitions which has been used and which is very much embedded in the clinical practice is that mean BP less than gestational age in weeks, and it is the so-called British Association of Perinatal Medicine rule. So this is used, but there is no evidence for it basically. So and also there is no something like one size fits all. So even if we see the BP in terms of gestational age, hours of life, and gender, uh, actually there is nothing that which fits all. So because we have to respect the dynamic physiological transition from the fetal to the neonatal life, and it is a complex underlying conditions. So we have to take in consideration everything. So what is a normal definition of BP? German Neonatal Network cohort study 2015, they suggest that the BAPM rule, which is the gestational age is equal to the mean BP, it can be overestimate in the extremely low birth weight gestational age neonates on the first day of life. So infants born at less than 29 weeks were found to have at least one median minimal BP, 1 to 2 mmHg below the equivalent gestational age in completed weeks. So in the ELBWs, the mean BP was found to be lower than one by the gestational age less than 1 to 2 mmHg. And also recently published study in 2019, it measured and calculated cerebral critical closing pressure in the extremely low birth weight babies and the So in that it found that lower mean median interquartile values were 20 and 19. So so defining hypotension, relying basically solely on the BP to determine whether or not an infant is in shock is problematic, because when BP is genuinely low, the patient may be in uncompensated state. Or if the BP is normal, it does not mean that the blood flow state is normal. And equally, a low BP can be present in absence of shock. So defining hypotension is a complex thing. So as per Swartz and colleagues in 2020, we have to accept that there are current limitations in definition and stop for a complete simple solutions for more complex issues. So he has advised that there can be a evaluating pressure and there can be a trigger pressure. So blood pressure basically. So initial evaluation pressure should be based around the gestational age equivalent values on day one, and trigger pressure is the value upon which one decides to intervene and is more complicated, and it should not be a single value alone. So the BP cannot be the only single value, but it can be a it can be important value in the setting of other important elements like clinical, biochemical, and other objective assessment criteria. So there is Focus New. This is the one online website which we commonly use for like the BP centiles. So this site is presently like not working. So it will show the as per the gestational age, postnatal days of life, and the gender. The mean BP, like the systolic, diastolic, and mean BP will be coming in fifth, 25th, 50th, and 95th percentiles. So fifth percentile is the definition for the hypotension as per this, and 25th is the target for the weaning target for the inotropes. So this is the we usually use this blood pressure centiles when we are managing the BP neonates in the NICU. Also, it is not at only blood pressure, but at least we know what is the low centile for this baby at this gestational age and this basically postnatal day of life. So, what is shock? Circulatory impairment leading to a state of impaired oxygen delivery to tissues. And normal cellular or tissue oxygenation depends on many factors, as we know: blood flow, oxygen saturation, transport capacity of the blood, and tissue oxygen demand. So, we have to consider that it is not a single thing to define hypotension. So, there are multiple variables which come into role. So, conventional physiological monitoring is blood pressure monitoring, heart rate, ECG saturation, and so other things, yeah, we have to look at the baby's age, postnatal age, birth weight, and just gender, as I told. Then risk factors for early or late onset infection or NEC in the medical history and pregnancy. Then we also need to have a circulatory assessment like echocardiography. So this is the most upcoming thing in management of any hemodynamic issue in the neonates. Bedside 2D echo. So it will rule out cardiac congenital cardiac disease, PDA, PPH diagnosis, and it will useful for assessment of cardiac function and even the flow states. So newer techniques which are there are NIRS, non-invasive, basically the cerebral blood flow measurement, non-invasive cardiac output monitoring is coming up, and pulsatile index. But all these three, they are still not in clinical use, and there is evidence that the cerebral blood flow monitoring. So we'll go to the evidence later, but the main things are clinical and the cardiac evaluation. And then there is, we have to analyze the baby and intuition and everything. And then clinical evaluation is capillary refill time, urine output, respiratory parameters, including instability, temperature. And subjective is how is the baby's general state, skin color, response to stimuli, clinical stability, and grade of activity. So in physiology, the we have to just have a look at the physiology and the pathophysiology. So in the neonatal myocardium, there will be few contractile elements compared to the older children and adults. So they are their neonatal, the myocardium is kind of at it is not capable of uh, like it has few contractile elements. It has basal contractile state which is higher and has higher sensitivity to changes in afterload, important in the context of removal of the placenta, so which is the low vascular state. So baby, when in the transition, baby is in the low vascular resistance state, and when the cord is clamped, baby goes to a high vascular resistance state. So obviously the myocardium becomes a disadvantage. So also there is higher water content, greater surface to volume ratio, immature sarcoplasmic reticulum, and reliance on extracellular calcium stores. So it is seen that lower superior vena cava flow rates are seen in large proportion of infants in the first 6 to 12 hours of life. So this transition which is there, it leads to a low flow state in the babies in the first few hours of life, and it can also have a low BP readings also, and it can be further complicated by fetal hypoxia and poor myocardial function. So which are the factors contributing to early cardiovascular insufficiency, like immature myocardium, as I told now, immature vasomotor tone, like decreased, they have systemic vascular resistance, increase, there can be increase or decrease, they can have altered effect of catecholamines, PDA can be there, sepsis can set in and cause cardiovascular insufficiency. Hypoxia can again affect the CVS status. Therapeutic hypothermia. So in the sepsis, it will affect the SVR as well as PVR. It can cause impaired contractility, reduced intravascular volume due to the capillary leak. In the hypoxia, there can be altered systemic vascular resistance. There can be high pulmonary vascular resistance and myocardial dysfunction. Therapeutic hypothermia again causes increased systemic vascular resistance, and it does decrease the heart rate, also decreases the reduced heart rate and cardiac output. And the respiratory conditions like PPHN, they will have high pulmonary vascular resistance. There will be right to left shunts and hypoxia. Mechanical ventilation again, it will have effect on the cardiac filling and on the preload. And the IVC can be preload can be less. And blood loss and early clot clamping. So basically, it reduces the blood volume and oxygen transport capacity and decreases the cardiac output. So about the early clot clamping, so basically it is not at all physiological. So pathophysiology of shock. So the shock, we have to see how it is happening. It is in the early hours, early few days of life, or it is late few days of life. So, because the baby's structural, metabolic, and developmental aspects of the CVS change over the first few of weeks of life. So, early hypotension. So, global assessment of an infant, including various clinical and biochemical parameters, addition to prior to intervening, and not based solely on BP. So, something is called as permissive hypotension. So, as we know, the physiologically initially the low flow states can be there, and also there can be low BPs. So, there is a concept called as permissive hypotension, so in which if there are isolated low BPs, then just like the fifth centile and just 1 or 2 mmHg below the fifth centile, are we going to intervene? So some advocate that we should not intervene and we should uh, accept isolated hypotension if it is not associated with metabolic acidosis, tachycardia, signs of cardiovascular instability, and organ dysfunction is not seen, like there are no high lactates, there is no metabolic acidosis, and cardiovascularly baby is stable. So that is the permissive hypotension. So what is the evidence for permissive hypotension? So many advocate permissive hypotension. So there was a EP2 nested match control cohort study in 2017. So it has shown that there is a higher incidence of significant brain injury in the lower BP group who did not receive any treatment, and compared to who received the treatment. So isolated hypotension can be damaging as per EP page 2, which was done in 2017. Uh, so there was a higher incidence of significant brain injury. So there were short-term outcomes in limiting inotropic therapy, and survival without severe morbidity was higher for the treated group when the BP was more low, like more than mean BP less than gestational age -5. So if it is the BP is more low, then again the severe morbidity will be higher if the baby is not treated. And but there were number of potential confounders, and so not factored into the analysis. So EP2 studies conclusions cannot be taken straight away. Then there was a trial, hypotension in preterm infants trial, HIP trial. It was carried out in 2015 to 17, and it again there is a restrictive versus more conventional approach. So more permissive hypotension as compared to the conventional approach in babies ELBW. This extremely low. This what I am saying, extreme just less than 28 weeks gestation babies. So actually what happened in this, the recruitment stopped after only for 58 participants were enrolled, just 7.7 patients were enrolled. So because of the challenges of enrollment. So what they found that 1 in 4 infants in the less than 28 weeks, they had mean BP less than their gestational age in the first 3 days of life, which can last for at least 15-minute period, and this can occur predominantly on day one. So a low BP on day one has been found in 1 out of 4 neonates in less than 28 weeks. So this was the HIP trial, and there was no difference in the primary outcomes of survival free of significant brain injury at 36 weeks corrected gestation in the restrictive versus conventional approach. Then, according to the HIP trial, their wait and watch approach is not unreasonable in this group of extreme preterm infants. So, but the data was very small, and they could not complete the study. So, no long-term outcomes were there. So, HIP trial also cannot be conclusive. So Safe Boost 3 trial, which happened in 2023, it was conducted in 70 sites in 17 countries, and it assigned extremely preterm babies to less than 28 weeks within 6 hours of birth to receiving treatment guided by cerebral oximetry monitoring for first 72 hours. So it was or for afterbirth to receive usual care. So 150, 1579 units were evaluated. So in the ELBW treatment guided by cerebral oximetry monitoring for the first 72 hours after birth, it was not associated with lower incidence of death or severe brain injury at 36 weeks PMA. So if we are using the cerebral blood flow and cerebral oximetry monitoring, it was not shown to be helpful. So about the permissive hypertension, there have been 2 trials and which have been non-conclusive. Also about the NIRS and the cerebral oximetry monitoring, Safe Boost 3 trial, which is the latest trial, it has shown that it has not helped because we cannot pick up if the baby is having cerebral hypoxia using the cerebral blood oximetry monitoring in the first 72 hours. And there was no difference and no benefit of using it. So then it comes what is the most important thing which has come up is bedside functional echocardiography. So, Ella said at et al., they have reported that there is faster clinical recovery in hemodynamically unstable neonates after implementation of comprehensive hemodynamic monitoring, including the use of neonatologist performed echocardiography. So definitely there is no doubt, and there is plenty of evidence that bedside 2D echo functional screening it does impact the outcome in a better way. So coming to the pathophysiology of shock, so basically we all know that there is a compensated phase of shock, and then it goes to the uncompensated phase. In the first phase of shock, when the perfusion oxygen delivery is maintained towards the so-called vital organs, heart, brain, and adrenal glands, importantly. So by selective regional vasodilation and diverting the blood flow from the muscle, skin, kidneys, and splanchnic tissue. So, so after the redistribution fails, the baby goes into a state of uncompensated shock when the systemic hypotension sets in. So basically, why we are looking at this is that uh, because it becomes controversial in the way that basically one important point is that even the forebrain in the preterm babies, it can be called a non-vital organ because it has been shown that the vasoconstrictive response is there in the forebrain in the preterm babies, and there is decreased perfusion when there is hypotension. So forebrain is a non-vital organ in has been shown to be non-vital organ in a study in preterm babies. And also the cerebral autoregulation. So we are looking at the blood pressure and the cerebral autoregulation. So this correlation is very important uh, because there can be a pressure passive cerebral perfusion. So in the very preterm babies, it has been shown that pressure based approach, it might lead to impaired perfusion and oxygenation of the cortex during the initial compensated phase of shock. So when the baby is in initial first compensated phase of shock, when the BPs are maintained, but still because their cerebral autoregulation is not very good, they can go into pressure like pressure passive cerebral autoregulation, and there can be cerebral hypoxia. So combination of low cardiac output with normal to high blood pressures suggest a compensated stage of shock. So means BPs are maintained, but the cardiac output is low and the cerebral perfusion is also low. So hyperdynamic circulation is characterized by normal to high cardiac output in combination with hypotension. So in the transitional preterm physiology, there is a physiological phenomena that exists where blood flow is normal and the BP can be low. So both things are there. BP can be low with normal blood flow, and also in the compensated stage of shock when the BP is normal, the flow can be low. So these things need to be taken into consideration. So how the first in the first day of life, how the baby's cardiovascular system goes through is, baby has to go from a low intrauterine vascular state to a high state. So in that, the myocardium is immature. There are shunts, uh, the blood out of the systemic circulation. If there is short cord clamping time, then it can, all this positive intrathoracic pressure from the ventilation, and all this can lead to low systemic blood flow and no spontaneous breath. So basically, before the start of spontaneous breaths, if the baby, the cord is clamped, definitely there will be low systemic blood flow. So this is important in context of avoiding low systemic blood flow. The cord clamping should not be early; it should be a delayed cord clamping, especially in vigorous babies. And the evidence for that is for the less than 28 weeks. There is no evidence for that, but if the babies are vigorous, delayed cord clamping is definitely indicated. Even the Cochrane review also indicates the same. So coming to the functional management, functional 2D echo based, uh, basically the stages of shock. So there can be stages of normal, compensated shock, uncompensated, and there can be a hyperdynamic circulation. So if we see here in the A, there is the cardiac output is high as well as the blood pressure is high, and this is normal. So in the D, if we can see, the cardiac output is high, but the blood pressure is low. So it happens in hyperdynamic circulation. And then if we look at B, the cardiac output is low and the blood pressure is low. So blood pressure is maintained, sorry. So it is compensated shock. And when both are low, BP as well as cardiac output are low, it is uncompensated shock. So we know the physiology. Blood pressure is directly proportional to the cardiac output into the systemic vascular resistance, where the cardiac output is heart rate into volume. And for the heart rate, arrhythmias can cause the heart rate to go low or high. Then the stroke volume is dependent on the preload, contractility, and the afterload. The preload is dependent on it can be affected by hypovolemia, diastolic dysfunction, and volume overload. Contractility can be affected by poor contractility and hyperdynamic circulation. Afterload, high afterload, and low afterload states. And the systemic vascular resistance, it is mainly affected by the neuroendocrine and paracrine regulatory mechanisms. It can have vasodilation and vasoconstriction. So low SVR and high SVR. So when we look at the baby with a cardiovascular compromise, so there can be different reasons, like vasodilation can be there in cases of septic shock, systemic inflammatory diseases like NEC, and pressure resistant hypotension. High afterload can be there because of maladaptation after birth and dilated cardiomyopathy. Hypovolemia, we know, acute blood loss, decreased placental transfusion, umbilical cord avulsion, subgaleal hemorrhage, insensible water loss, polyuria, and RV dysfunction. Poor contractility, like in asphyxia, perinatal depression. Septic shock can also have poor contractility, dilated cardiomyopathy, and LV non-compaction. Obviously, the heart rate, the cardiovascular compromise can be due to the shunt and arrhythmias like PDA, AV malformations, and SVT, and diastolic dysfunction, like because the baby's neonates have immature myocardium, there can be tension pneumothorax, cardiac tamponade, hypertrophic cardiomyopathy. So all these factors they come into role when there is a cardiovascular compromise. So looking at we will go to the inotropes. So just a small recap on the adrenergic receptors. Beta 1 is located in the myocardium, and it will cause inotropy, increase in the pumping and the contractility, chronotropy, which is increase in heart rate, bromotropy, which is increase in the conduction. So beta 2 is in the systemic and pulmonary arterioles, and it causes vasodilation on stimulation. Alpha 1, it is in the myocardium, which can cause increased inotropy. It is there in the systemic and it is there in the systemic arterioles, skin, skeletal muscles, abdominal viscera, kidney, everywhere, and it can cause peripheral vasoconstriction basically. So alpha 1 on the heart causes mild inotropy, and basically alpha 1 receptor stimulation causes peripheral vasoconstriction. So looking at the inotropes, so we know different inotropes, they will work in different, when the doses are different, the receptors which are stimulated, it goes on changing. So dopamine, when it is given in a low dose, it has been postulated that It will act on only on the dopaminic receptors, dopaminergic receptors 1 and 2, and it will cause renal and mesenteric dilatation. At 4 to 10, it will act on the alpha receptors and it will cause inotropic effects. At 11 to 20, the higher doses, beta receptors will be stimulated. It will have vasopressor. So basically, the peripheral vasoconstriction, increase in SVR, and also it causes increase in the peripheral pulmonary vascular resistance. So this is a drug we have to keep in mind that dopamine does cause increase in pulmonary vascular resistance, and the effects which we expect for the dopamine, it should be in the 4 to 10 microgram per kg per minute, the inotropic effect which we expect. Then the dobutamine, the dose is 5 to 20 microgram per kg per minute. It acts on the beta 1 and beta 2 receptors. On the beta 1 receptors, it will cause inotropic effects, and then the beta 2 receptors, it will cause the decrease in SVR. It will inotropic effects are increase in cardiac output. Epinephrine, it stimulates all the adrenergic receptors, basically alpha 1, beta 1, beta 2. From the alpha 1, it will cause inotropic effects as well as it will decrease the SVR. But when we go to the higher doses, then there is vasopressor effect and increase in the SVR. So the initial decrease in the SVR, it gets converted to increase in the SVR when you go to the higher doses in epinephrine. So if we want to give epinephrine, we should give in small, like lesser doses, like 0.1 to 0.3 microgram per kg per minute. So the more of the inotropic effect is there, and in fact, it decreases the SVR in those doses. But once we cross the zero point 0.4 microgram per kg per minute, then there is increase in the systemic vascular resistance. So norepinephrine, the again doses is 0.1 to 1 microgram per kg per minute. It acts on the alpha 1 and alpha 2. It has vasopressor effects, and it increases the systemic vascular resistance. So it has a role in the vasodilatory shock when it is not responding to the other inotropes. And hydrocortisone, we know it enhances sensitivity to catecholamines. The dose is 1 to 3 mg per kg per minute, and it can be given, it is usually given 8 hourly. And we don't know how it actually works, but it enhances sensitivity to catecholamines. And the later evidence, it is showing some evidence that I will come to it later, how hydrocortisone acts. So then the vasopressin, it acts on the vasopressin 1 receptors. It increases only the SVR, and there is no inotropic effect at all for vasopressin. There is a point to be noted that vasopressin does not increase the pulmonary vascular resistance. Then milrinone and levosimendan, these are the two drugs which are uh, lucitropic effects. So milrinone has phosphodiesterase 3 inhibitor. It is a phosphodiesterase 3 inhibitor, and it produces effects in beta 1 and beta 2. So it has inodilator. So it has inotropic properties and peripheral vasodilation. It causes good relaxation of the heart. It increases contractility and decreases the SVR. So it is a very good drug in the failing heart, especially in post-cardiac surgery patients also. And levosimendan, it is not really commonly used in neonatal patients, but it is a similar drug like the milrinone, inodilator, and without increasing the myocardial oxygen demand, which is a advantage for levosimendan. So so according to the, if we go not by the BP and we go by the flow states, so how do we manage the hypotension? So low systemic blood flow, then systemic hypotension. So is it due to the low, is the diastolic BP low, is the systolic BP low, or both are low? So if the diastolic BP is low, it can be low because of the decreased afterload or decreased preload. So if it can be because of the decreased SVR, like in septic shock, NEC, a systemic inflammatory response syndrome, PDA, in the donor, in the twin to twin transfusion syndrome, in the donor, the yeah, because there will be decreased afterload, there will be anemic and all. So AV malformations, giant hemangioma, and lung sequestration. So in this case, when the afterload is less, so for the decreased systemic vascular resistance, vasopressors come into role: dopamine, epinephrine, norepinephrine, and vasopressin. Volume expansion, ionopressors, like, so the drugs can be divided into inotrope, ionopressor, inodilator, So it comes like that. So for the SIRS, we use hydrocortisone. For PDA, NSAID, and ligation. For the preload, so this is basically the flow-based management. So we have to do the 2D echo, and there are parameters which will show the systemic blood flow is uh, good, it is low, and it also depends on the BPs. So I am not discussing the 2D echo parameters which will show the flow states, but I'll come to it later. So the if the preload is less, it could be because of hypovolemia, then decreased venous return. So it could be because of tension, pneumothorax, high mean airway pressures, and cardiac tamponade. So for all these states, preload is low. Definitely hypovolemia will treat with volume expansion, and vasopressors are used like norepinephrine and vasopressin. And for the decreased venous return, again, other causes of airway management we can take care of better, so that the venous return is better by decreasing the mean airway pressure. If the pneumothorax is there, pleural drainage, and all those things. Then, if the systemic blood flow, systolic BP is less, arterial BP is less, it can be because of decreased contractility or increased afterload. So, if the contractility is low, myocardial dysfunction is there. It can be cases of there in cases of asphyxia, cardiomyopathy, PPHN, recipients in TT, twin to twin transfusion syndrome, and adrenocortical insufficiency. It can cause decreased myocardial dysfunction and early pneumothorax or pericardial effusion. So in those cases, basically, if the systolic BP is low, then systolic BP is low with poor myocardial contractility. In this case, we prefer a drug which is inotrope as well as a vasopressor, because we want good contractility. We also want better BP. So in this case, dopamine and epinephrine are used, because dobutamine and epinephrine. So dobutamine will increase the contractility, and epinephrine will increase the systemic vascular resistance as well as the BP. So, and the lusitropes like milrinone for PPH and INO. So I think we will come to all these details. I have taken case-based scenarios and everything. So we can come to it later, I think, rather than going through this at exhaustive. It is a very exhaustive table. So what is the evidence for antihypertensive interventions? So we will come to the what is the evidence basically. So what is the evidence for volume expansion? What is the evidence for the inotropes? What is the evidence for the glucocorticoids? And what the evidence says, and then what can we derive from it. So evidence for volume expansion. So volume expansion, definitely it will be life saving in a truly hypotensive baby, hypovolumic baby. But if the baby is normovolumic and then we give a fluid bolus, then it will immediately increase the cardiac output, but we don't know how long it will stay into uh, the volume stays into the circulation. It can go extravascular, and when it goes to the extravascular space, then obviously it will have side effects. Also, if we are continuously giving boluses, the distribution of extra volume out of the intravascular compartment, it will create interstitial edema in the lungs and other organs of the body. So, the volume expansion, the theory that this is the there is a Iowa handbook for cardiology in 2012. It has come out. So, in it showed the volume expansion works in as like we can see this graph. So this is the cardiac output, and basically this, if we see, sorry, the relationship between the preload and the stroke volume. So the stroke volume we can see. So as the preload increases, stroke volume will increase, and we can see here. So, and this is the Marek-Phillips curve, dotted line. So at low preload, most patients they will respond to a fluid bolus. So they will respond with the stroke volume will improve very nicely. So here also we can see that. And if the further up the curve, fluid responsiveness becomes unpredictable. So here we can see the extravascular lung volume, it goes on increasing. So after a time, the next the fluid which we are giving extra, it will go to the lungs. So extravascular lung volume will increase, and the stroke volume will not increase. So when the baby is hypovolumic, at that time the stroke volume will increase very nicely. Later it will come to a plateau phase, and then the stroke volume would increase. We know that. But at that time, the blood, the excess volume which we are giving, it will extravasate into the interstitial compartment, and lung volume, lung fluid is increasing. So extravascular lung water is more, And it is shown that excessive fluid expansion is really not good, and it may lead to the accumulation of water into the lungs. So what is the evidence for it? So this was a theory. What is the evidence? Evidence says that excessive volume expansion in preterm babies may be associated with higher mortality. So if one bolus may be they have seen, if we are giving excessive volume in preterm babies, it has been shown to be associated with higher mortality. So what is the effect on the cerebral blood flow? So xenon extraction or near infrared spectroscopy, it has shown it does not seem to be consistently increase. So cerebral blood flow is not increased by volume in hypotensive preterm infants. So if we are giving volume, it may not increase the cerebral blood flow. And relative hypovolemia in the context of mechanical ventilated patients, when especially when we are intubating them, at that time, giving a bolus is definitely it has a merit, because it will increase the mean airway pressure and it decrease the venous return to the heart. So given one bolus at that time, not in the excess of 20 ml per kg, should be it can be used definitely. And it is mentioned that there is no clear cut diagnosis of hypovolemia, we should avoid going exceeding 20 ml per kg of fluid boluses. So coming to the evidence for the inotropes, evidence for a dopamine. So data shows that it is more effective than volume and dobutamine at increasing BP. So it is similarly, the efficacy is similar to the epinephrine. It is efficacy is similar to the steroids and vasopressin. And the effect on mean BP is due to the vasopressor effect. So it increases the systemic vascular resistance. So, but how it does it impact the cerebral blood flow? It is very less consistent results are there. So if we say it is more effective in raising the BP, and it is good as other inotropes like epinephrine, steroids, and vasopressin. So in dopamine doses between 4 to 10 microgram, it will increase cardiac output. It has been shown to increase the cardiac output in late preterm and term infants, mostly of whom were asphyxiated. So this is the only one study which is showing that it has increased the cardiac output. Otherwise, they show many of the studies have shown there is no significant increase effect on the cardiac output. In fact, it can reduce the left ventricular output in a dose of dopamine when it is used for the sufficient to normalize the BP. And the other study by Osborne has shown there is no change in superior vena cava flow, so which is the flow coming from the so it is indirect indicator of the cerebral blood flow. So there is no change in the superior vena cava flow. Also, uh, if we go at higher doses, 10 to 20 microgram per kg, the same study by Osborne has shown that alpha adrenergic effect is there at higher doses. So there is no evidence that any vasoconstriction it will limit the cerebral blood flow. So basically, if the evidence all this shows that there is no increase in cardiac output, in fact, it can decrease, but overall, other studies also showing there is no increase in the cardiac output, but it increases the BP, and there is no increase in the superior vena cava flow. So overall, in in the for the cerebral blood flow, also it has shown that either it increases the blood flow or it has no change. So it can be definitely useful. So this is one thing which can be useful for dopamine. And then if we look at what is the evidence? So Boiseau et al. He has shown that there is increase in pulmonary artery pressure in response to 8 mcg per kg per minute of dopamine, 8 microgram per kg per minute of dopamine. So there is increase in pulmonary artery pressure as per the evidence. So this is the evidence. Then for the evidence of dopamine summary, dopamine will reliably increase the blood pressure, but it does this more by increasing systemic vascular resistance than the blood flow. So if the blood flow is not good, then it might not be the agent of choice. And then it likely increases the cerebral blood flow. So this is a good point which we can use while instituting inotropic therapy. Also, higher doses should be avoided because it will increase the cardiac afterload and cause peripheral vasoconstriction. And inhibition of TSH production in the pituitary gland, it has a special clinical relevance in the newborns. So hypothyrotropinemia can be there. So we do not do the in clinical practice also when the dopamine is going on, we do not send the TSH, the thyroid profile levels, because of this inhibition of the TSH production in the pituitary gland when the dopamine is going on. And but if we ask for what is the impact of dopamine on the clinical outcomes, there is no evidence for it. So for summarizing, for dopamine, it increases the BP by increasing the systemic vascular resistance, but it does not increase the cardiac output as reliably, and high doses are not really beneficial. And TSH can be production can be less, so we have to watch for that. So, what is the evidence as per the Cochrane in dopamine versus dobutamine? So, they have checked in hypotensive preterm babies. So, there is no evidence of significant difference between dopamine and dobutamine in terms of mortality, periventricular leukomalacia, or severe periventricular hemorrhage. So, this was in 2003. So, when they have seen compared these two, there is no difference in between these two. So, dopamine was, Cochrane review also says, more successful than dobutamine in treating systemic hypotension. And Cochrane review also says that dobutamine was associated with significantly increase in the left ventricular output. And but in the absence of data confirming long-term benefits, so there is no data on the long-term benefits of dopamine and comparing the dobutamine. So if we ask which is the better, what the evidence says, there is no firm recommendation regarding the choice of drug to treat hypertension. So again, we are at a gray area. So then we come to the dobutamine, but we know what are the flow states and how they are how the inotropes are affecting the flow states, and depending on that, we can choose the inotrope. But there are no robust studies which are showing what is the impact on the clinical outcome. So what is the evidence for dobutamine? So we know it has a uh, the evidence is showing the some one study is showing that the vasodilatory effect of dobutamine is likely, and clinical trials have shown it is dobutamine is not as good as dopamine in improving blood pressure in hypotensive preterm babies, but it seems to improve the blood flow. This is what we have seen, and there was no difference in neurodevelopment at 3 years in only one trial to report this, and this trial was not powered to the outcome. So the neurodevelopment outcomes when the baby was treated with dobutamine in hypotensive babies, there is no, so outcome data is not there basically. Then when there was a one small RCT which compared dobutamine to placebo, and with low systemic blood flow, and showed that systemic blood flow improved in both groups. So placebo also improved it, but other markers of perfusion were significantly better in the babies with dobutamine. And it showed no difference in the changes in the cerebral blood flow in difference in the dobutamine or placebo. So there is one study, Bravo et al. He has described placebo effect that most blood flow parameters will improve spontaneously after 12 hours of age in very preterm infants. So when they had compared dobutamine and placebo, so the blood flow parameters had improved. But when he compared with placebo, they had improved spontaneously. So we do not know how much it is contributable to the dobutamine. So there is a placebo effect also when the blood flow will improve spontaneously in 12 hours in very preterm babies. So what is the evidence for summary of dobutamine? So it has dose-related central inotropic and chronotropic effects with peripheral vasodilatation. It is likely to be most effective when there is myocardial dysfunction because it is a good inotrope, and or increased afterload. It also causes peripheral vasodilatation, and it leads to low systemic blood flow, and it is unlikely to be effective when hypotension is due to the vasodilation. But if you ask what is the evidence, so evidence is for the clinical outcomes, it is not there. But if we look at the flow states, then for low flows, low cardiac output, dobutamine is definitely working in the preterm babies. But with hypotension, it is there, then that cannot be the first or the only drug to be used. Then coming to epinephrine has dose-related effect just like dopamine. So there is a previously RCT was there in which dopamine and epinephrine were compared in hypotensive preterm infants. So there was similar improvement in the BP, cerebral oxygenation index, and epinephrine group, but had higher lactate and more hyperglycemia. So this was the disadvantage which was shown in the RCT. So when we are comparing dopamine and epinephrine in hypotensive preterm babies, so BP is fine. Both are showing similar BP. Both are showing similar improvement in the cerebral blood flow. But this is a side effect which has been observed. That is the hyperlactatemia and hyperglycemia. So uh, also there was a neurodevelopmental outcome. They showed no difference between the two groups, the dopamine and epinephrine. So there is no difference in the outcomes. So in summary, the vasoconstrictive effects of epinephrine make it best suited for the management of vasodilatory shock. So also the caution should be applied because higher doses will cause high risk of afterload. So evidence for the adrenaline continuity showing it will have effect on the beta mediated effects at lower doses and alpha mediated effects at the higher doses. So higher doses are not definitely advised, and it increases the serum lactate and metabolic acidosis. So if we see even in the babies in the neonates, there are not enough studies in which the adrenaline has been used as the first line agent, and maximum of the studies have shown that dopamine is the drug which has been used most commonly as the first inotrope in the neonates. And it has been shown to be safe as compared to the adrenaline because the dose exceeds the, it increases the afterload, and it also increases the need for the insulin in hyperglycemia and it will increase the lactate levels also. So overall evidence for adrenaline is the studies which have included adrenaline, they are very less actually. So evidence for norepinephrine, again, it will be on the studies which have uh, studied the norepinephrine, they are actually very less. So there is no clinical trial evidence on the use of epinephrine in the newborn babies and not much observational studies also. So in norepinephrine, we do not have much evidence. So no RCTs basically, and observational studies are also very less. So the retrospective study of norepinephrine used in 48 babies born before 33 weeks showed that normotension could be achieved in a mediate dose of 0.5 mcg per kg per minute. So the dose is, as per them, was 0.5 was good to achieve normotension, and there was only tachycardia, no other immediate side effects. So there was one small cohort study which showed improvement in blood pressure in term babies with septic shock, which was refractory to dopamine and dobutamine. So, because of its peripheral vasoconstriction effects and inotropic effect, so when there is a shock which is resistant to dopa and dobuta, norepinephrine has been shown to be beneficial in term babies in improving the blood pressure. So, observational study in term babies with PPHN suggested that norepinephrine has beneficial effect on both systemic and pulmonary hemodynamics. So it does not, in fact, it does not increase the pulmonary pressures. But there is no long-term safety data on use of norepinephrine, but it may have a role in refractory vasodilatory shock and in babies with PPHN with low blood pressure, causing systemic vasoconstriction and vasodilatation. So if we ask, the studies are less, but it shows improved BP, especially when the babies were interim babies who had not responded to dopa and dobutamine, and it decreases the pulmonary vascular pressures, but there are no long-term safety data, and so it cannot be recommended. Like we cannot give a straightforward recommendation for the use, and it has been, but it may have a role in refractory vasodilatory shock and in babies with PPHN with low blood pressure. So PPHN with low blood pressure, definitely norepinephrine can be vasoactive drug. It can be a useful drug, and in refractory vasodilatory shocks. So it is not a definitely we are not using noradrenaline as the first choice or second choice, and also the evidence also shows the same thing. So the evidence animal studies have shown it increases the SVR, but it decreases the pulmonary and increases the pulmonary blood flow also, and therefore it improves the outcome in pulmonary hypertension. So the infants born more than 35 weeks gestational age with PPHN, they have demonstrated, Tornex et al. Have shown improved lung and cardiac functions. And a recent adult study found that noradrenaline was associated with more enterocyte damage, which might be an important factor to consider in preterm babies. So, related to NEC, it can be like it is an adult study. So there are no studies for the neonate, but it can be an important factor we need to keep in mind, especially considering the enterocyte damage in the adult study. So relevant to the causation of NEC. but no direct evidence or no direct study in the neonates. Then evidence it can be used especially when the vascular tone is low in warm shock, and risk et al. Found that it improved BP, urine output, oxygen dependency in a retrospective study of preterm infants treated with norepinephrine for septic shock. So for septic shock, norepinephrine has been used by risk et al. And he has shown that BP had improved and the parameters of end organ perfusion also improved, and the oxygen dependency was also less in preterm infants with in treated with norepinephrine. So norepinephrine, as per him, is good choice for septic shock. So coming to vasopressin, again, vasopressin is very rarely used, and there are very less studies. There is only one RCT which has compared vasopressin with dopamine in hypotensive infants. So dopamine is the most commonly used drug, and they have the authors have compared dopamine and vasopressin. So the both agents had similar effects in increasing BP. Vasopressin had less tachycardia. So vasopressin acts peripherally. It increases only the systemic vascular resistance. So it increases the BP, but no effect on the heart rate. And otherwise, there are small series of improvement in blood pressure in preterm babies with inotrope refractory hypotension. So here it is good. Vasopressin is as good as dopamine for increasing the BP. No effect on the cardiac output. And in preterm babies with inotrope refractory shock, in that case, there is evidence for use of vasopressin. So in the refractory hypotension, it can be used and it has been shown to be improving the blood pressure. So the continuing the evidence for vasopressin, it has a vasodilatory effect on the pulmonary vasculature. So there is the evidence from animal studies, and this would be consistent with the observational report on the use of vasopressin in 10 babies with PPHN who were refractory to inhaled nitric oxide. So when we are dealing with PPHN, which is refractory to INO, then this is something which can come to our help. So vasopressin infusion has like this evidence. It has shown in 10 babies with PPHN that if vasopressin infusion improved blood pressures, it reduced oxygenation index and improved the urine output also. But there is not enough safety data to routinely recommend vasopressin in PPHN. But it may have a role in vasodilatory shock refractory to vasopressor inotropes, and some evidence is there in babies with PPHN with which are refractory to INO. So vasopressin and its analog for the treatment of refractory hypotension in neonate, Cochrane review in 2013, it is showing there is insufficient evidence to recommend or refute the use of vasopressin or its analog in the treatment of refractory hypotension in neonates. They actually so there was actually no studies only for vasopressin. Their search did not find any studies completed or ongoing that met the inclusion criteria. So there is no evidence to tell about the vasopressin. So coming to milrinone, but the vasopressin is like we saw in the evidence, it is helpful in PPHN, uh, resistant to INO, and as a agent which can be used in refractory cases of shock. So coming to milrinone, the large RCT has shown that milrinone significantly reduces the incidence of low cardiac output state in neonatal and pediatric populations. So this is definitely useful when after there is PDA ligation. So afterload reducing properties of milrinone led to observational study that suggested that milrinone may prevent the afterload compromise that can follow PDA ligation in preterm babies. So also, there is a hypotensive effect of milrinone which has been shown in these studies. So for the post cardiac surgery cases, milrinone, especially post PDA ligation, this it has been shown to prevent the afterload, because after the post when the PDA is ligated, so there can be a state of low cardiac output. So so in this case, the milrinone has been found to be essential, useful. So the pulmonary vasodilatory properties may also explain the observation of improvement in oxygenation and hemodynamics in babies with PPHN refractory to inhaled nitric oxide. So along with vasopressin, milrinone is also one drug which has shown use in along with refractory cases in the cases with refractory to INO. So pulmonary vasodilatory properties are helpful over here, and it is associated with systemic or pulmonary vasoconstriction, but there is not enough safety data to recommend routine use. So milrinone also, there is no evidence that it will tell her this is the first line drug for this or the second line drug for that. There is no evidence for that. So again, we have to see how helpful it was, in which studies, in which states of flow, in which states of pulmonary pressures, and then we can yeah, like clinically use it in a better way. So it should be used with caution in very preterm babies, because it has very long half life and there is his risk of hypotension. So we do clinically see in NSU whenever there is myocardial dysfunction, especially in babies with severe PPHN or INO, and we do want to start milrinone. So baby immediately goes into hypotension, and we need to stop milrinone and we need to come back on dovitamin. In all those cases, especially the meconium aspiration and the birth asphyxia cases where there is this what do you say, myocardial dysfunction. So milrinone does definitely cause hypotension because of the peripheral vasodilatory properties. So coming to a kind of composite, there is in 2007 there was a Cochrane review, effect of inotropes on morbidity and mortality in preterm infants with low systemic or organ blood flow. So this is about the outcome. So what they have mentioned, that there is some evidence that dobutamine is better than dopamine at increasing and maintaining the systemic blood flow. The only eligible trial did not demonstrate any consistent differences in the clinical outcome. So what they have seen, it is unclear which is the most effective strategy for improving CV status for immature infants in the first day. So for the preterm infants, there is a lack of evidence which is the best drug, the vasoactive agent they are saying. So and further trials are needed basically. So evidence for this was the last Cochrane review, which is showing which one is the better drug. So evidence for coming to the hydrocortisone. So in a review of circulatory support measures in US pediatric healthcare information system, they have found was hydrocortisone was the drug which was used second to dopamine, and dopamine was the first most commonly used, and second is the hydrocortisone, especially in the ELBWs. So we don't know about the what is the hemodynamic impact, but we know that it improves the BP. So what are the evidence? The NG et al. Has randomized preterm babies needing more than 10 microgram per kg per minute of dopamine to hydrocortisone or placebo, and he showed that there was faster weaning of inotropes in those treated with hydrocortisone. So definitely hydrocortisone will cause faster weaning of the inotropes, and it definitely improves the blood pressures. So one study has looked at the hemodynamic effects of the hydrocortisone. Only one study was there. So in a cohort of 15 preterm and 5 term babies with hypotension requiring high dose of dopamine, Nouri et al. Has shown that the immediate effect of hydrocortisone on blood pressure, it was mediated by increase in the systemic vascular resistance without change in the cardiac output or the stroke volume. So it has the hydrocortisone has kind of upregulated the this catecholamine receptors in the peripheral vascular circulation, and that has increased the uh, systemic vascular resistance and increased the BP, and without change in the cardiac output or stroke volume. So it has not acted on the heart, but it has acted on the periphery. So this was the hemodynamic effect seen by of hydrocortisone, studied by Nouri et al. But we know that it improves the it upregulates the receptors for the catecholamines in the heart as well as the peripheries. So peripheral action was more predominant, which was observed by Nouri et al. So with the weaning of dopamine, there was increase in stroke volume and cardiac output. So later there was increase in stroke volume and cardiac output also. So later the heart effects of improving the receptors for the catecholamines was also seen. But none of these studies have looked at the longer term outcomes. So long-term outcomes for hydrocortisone are not known. So this is the one of the latest PubMed articles, which was in 2022 June. Systematic review and meta-analysis of CVS medications in neonatal hypotension. So the meta-analysis is it was a systematic review and pairwise meta-analysis of the antihypertensive treatments in preterm as well as term babies to evaluate the efficacy and impact on outcomes. So Sorry, the slide is not yeah, here. So basically, here again they have just a minute. Here in that, the analysis has showed again the same thing, that dopamine had increased the cardiac output, and dopamine was helpful in the states of low blood pressure. But there was no other for the hydrocortisone, milrinone, vasopressin, epinephrine, or epinephrine. There were no enough evidence for recommendations, but they can be used in specific disease states or flow states, or the clinical condition. So coming to the disease states, HI, we know in HI there is pulmonary hypertension, there is myocardial dysfunction, and there can be an element of adrenal insufficiency also. Also, when the baby is treated with hypothermia, there will be peripheral increased systemic vascular resistance. It will also cause increased CNS redistribution will be there, and there will be also effects when there will be rewarming. So in HI, the right ventricular dysfunction is associated with adverse outcomes. Pulmonary hypertension has been shown it often exacerbates a degree of circulatory compromise, and its presence is associated with abnormal MRI on brain. So, pulmonary hypertension is shown to have adverse outcomes in the brain imaging on MRI. So, the main management for HI, it primarily goal is reducing the pulmonary vascular resistance and enhancing the right ventricular output. So this was a study which has showed this. So if we come to the management, so if the diastolic in the HI or therapeutic hypothermia and cardiovascular instability, the diastolic BP is low, less than 20 mm Hg, and systolic BP is low, then how we proceed? So if the diastolic BP can be low because of sepsis and adrenal insufficiency, vasodilation, and medication side effects. So the suggested thing is, in HI also hydrocortisone has been suggested, and judicious use of vasopressors. So if FiO2 is less than 0.6, 60%, then norepinephrine. But if the FiO2 is more than 60%, then first line they have suggested as vasopressin. So this is from the cardiology handbook of NICU of Iowa. So this is their recommendation. And if the systolic BP was less than 50, hypoxemia is there, then lung optimization, sedation, and iono is there. But if there is no hypoxemia, then we have to do a 2D echo, and we have to see first rule out the congenital heart disease. So if there is RV dysfunction, mild dobutamine, severe, then low dose epinephrine can be first line. If there is LV dysfunction, again dobutamine, and severe, then low dose epinephrine. Persistent dysfunction is there, PDA is closed or restrictive, PGE1 can be used. So in the HI, if we see for the PPHN, INO is there. And here they have mentioned if the uh, like hypoxemic pulmonary hypoxemia is there, then the vasopressor which they have used is vasopressin. And if the hypoxemia is less, then the norepinephrine is used. But here we see there is no dopamine. So norepinephrine and vasopressin have taken place over here. So hydrocortisone in HIV, there is an HI, there is evidence hydrocortisone may play a significant specific role in neonatal encephalopathy, as physiological responses to stress may be impaired. So there is a recent RCT which has compared low dose hydrocortisone to placebo in BP on BP in addition to dopamine in term infants undergoing therapeutic hypothermia with low BP and not responding to fluid boluses. So in baby with low therapeutic hypothermia, undergoing therapeutic hypothermia, term baby with low BP, so in addition to dopamine, so hydrocortisone or placebo was given, and they found that hydrocortisone increased the BP within 2 hours. And but short term and outcomes, they have not, they were unaffected. So hydrocortisone has a role in HI. So especially after the babies on dopamine, and there is still hypotension. So this RCT has shown, so second line drug which can be used with hydrocortisone, because there can be relative adrenal insufficiency in HI, and so hydrocortisone can help in HI. So coming to septic shock, this is the one of the uh, kind of more common scenarios we see in NICU. So septic shock can be early onset sepsis and late onset sepsis. So also it can be cold shock and warm shock. So I'll skip. So I'll in the study in the Iowa handbook, it has shown. So there are studies from 2010 to 2022, and term as well as preterm babies were included. So late onset sepsis as well as early onset sepsis cases they have included, and they have seen that the sepsis is usually associated with, maximum of the studies are they showing that it is usually associated with high systemic blood flow. So high systemic blood flow is has been shown in these studies, and cardiac dysfunction is very much common. So high systemic blood flow and cardiac dysfunction, these are the two pathophysiological hemodynamic compromises which can be seen in sepsis in early as well as late onset. So here also we can see early onset and late onset both are present. Here also in early onset, late onset. So maximum of the studies are pointing to that there is significant cardiac dysfunction and high systemic blood flow in sepsis, and the mortality has been quite significant from up to 70% also. So, for the evidence for treatment of septic shock, so if we compare the pediatric sepsis guidelines, uh, the what they have shown that volume, like first is thing in the sepsis is 40 to 60 ml per kg of volume is given, and tried to, and the drugs which are used are epinephrine or norepinephrine, even in the adults also. So for the septic shock, epinephrine or norepinephrine are used after the fluid boluses, and then dopamine is not the first drug. And after the epinephrine or epinephrine, vasopressin is used in the non-responders. So these are the most recommendations for the pediatric shock. So, but all these recommendations were weak based on low or very low quality of evidence in the pediatric studies. So, but there is positive data about the volume resuscitation and inotrope administration in septic shock in newborns. So, data is not much. So, rapid volume administration has been shown to be associated with coagulopathy in animal studies. So, once we come to septic shock, definitely we are talking about the volume replacement first. We always say that in septic shock we can give more volume. There is scope of giving more volume. The shock is responsive to volume, and then we go to the inotropes. So, what talking about how much volume we can give and which is the inotrope in the septic shock in units. So, rapid volume administration has been associated with coagulopathy in the new animal models. In the preterm neonates, volume has been associated with increased risk of IVH and mortality. So, even if septic shock is there, we have to be judicious, especially in preterm babies, because there can be increased risk of IVH. Then, higher versus lower fluids, they have been shown increased risk of PDA as well as chronic lung disease in preterm infants. So, all these data suggest that volume should be used judicially, particularly in preterm babies. And if we compare for the volume, which is the crystalloids or colloids, so definitely the trials are towards the colloid, they're indicating towards the colloids, and normal saline seems to be reasonable rather than albumin as a general rule. But balanced buffered crystalloids like plasma light A can be alternative to saline based on very low quality evidence, but there is no significant good evidence to uh, show other crystalloids other than the NS. So for the septic shock, judicious fluid volume expansion, especially in preterm babies with normal saline, is the current evidence which is showing. And then, unlike the pediatric and adult world, dopamine remains the first line agent in the neonatal care, because if we see that the epidemiological information also from large databases, they also showed that dopamine has been, most of the RCTs have used the dopamine as primary inotrope. The reason is that there is why it is like kind of first drug which is recommended based on many of the studies, because it does increase the BP. Then clinicians are familiar with its use, and also if you remember, it has a increase, it can increase the cerebral blood flow, if or maybe no change, but it does have a positive effect on the cerebral blood flow. So Basque et al found that comparable efficacy of epinephrine versus dopamine in RCT of neonatal septic shock fluid non-responders. So the neonatal septic shock fluid is given, and then we want to see epinephrine or dopamine. So Basque et al he has seen that both are working similar. So epidemiological studies have also confirmed the same findings, and So most of the RCTs have included dopamine, almost 18 of 21. So the thing is that only that we have better experience with dopamine than the norepinephrine. So for the septic shock, presently the evidence is pointing towards dopamine. If we compare it with adrenaline, then as the dose increases even slightly, the afterload increases. So there needs to be a close monitoring and titration. Also, there is a risk of hyperinsulinemia, hyperglycemia and high lactates. So somehow dopamine has been found to be maybe safer than epinephrine. So it does not increase the cardiac output, but still it is the agent which is being used because septic shock is more of a vasodilatory shock. So dopamine is being used. But if there is a component of PPHN setting in, then dopamine is definitely not the agent to be considered. So if what is the evidence for early onset sepsis, late onset sepsis, and INO? So Deshpande et al. Has found that in 33 mostly preterm babies, so most of the patients had mild, moderate, or severe pulmonary hypertension, and that the elevated pulmonary arterial hypertension in early onset sepsis, it can be a mix of raised pulmonary vascular pressure and increased left atrial pressures. So in the early onset sepsis, inhaled nitric oxide is currently the treatment of choice in sepsis-induced pulmonary hypertension during the transitional period. So, in the first transitional period, in the first few days of life, if there is early onset sepsis, along with PPHN, then inhaled nitric oxide is the treatment of choice, especially when the pulmonary blood flow is low and but with the late onset sepsis, INO should be used cautiously because those babies have high pulmonary blood flow, hyperdynamic kind of PPHN. So in the early onset sepsis, there is a low pulmonary blood flow kind of PPHN. There the INO is helpful. So there is the evidence for that. And echo examination is must when we are thinking of giving INO to a baby with late onset sepsis. So in units with late onset sepsis, it might be predominantly driven by the increased pulmonary blood flow and raised left atrial pressures. So this is the evidence that inhaled nitric oxide can be effective in early onset sepsis, but not in preterm babies with late onset sepsis. Two studies are showing that. And inhaled nitric oxide, as I showed, sepsis-induced pulmonary hypertension in the first early onset, it is good. It is the recommendation. So for the post cardiac surgery, as I told, low cardiac output states are there. And in the Primacorp study found that the high doses of milrinone resulted in significant reduction in incidence of low cardiac output states in 36 hours following cardiac surgery. So this milrinone is now the most common used agent for the cardiac surgery. And levosimendan is also used, but data on long-term safety is not there. For the post-cardiac surgery, the milrinone evidence is towards the milrinone. It does decrease the low cardiac output states, especially in the 36 hours following the cardiac surgery. And it also improves the cerebral oxygenation, systemic perfusion, and levosimendan compared to milrinone without an increase in the myocardial oxygen demand. So this is the study, but other studies are not there. So in a recent double-blind RCT by Wang et al. In 187 infants undergoing cardiac surgery, primary outcome of low cardiac output state did not differ between both of the levosimendan and placebo. So overall, if we find the milrinone is presently the drug for the post-cardiac surgery, then coming to PDA, as such, there is PDA in the hypotension in PDA can be resistant both to volume and shock, volume and inotropes. So for the PDA as such, there is no choice for inotrope. But if the output is less, then dobutamine should be considered. And if the BP is low, then dopamine should be considered. So there is no evidence as such for it. And they have written basically early treatment for PDA. It does result in lower incidence of hypotension requiring inotropes within the first week of life. So for the PDA, basically early closure. For the HSPDA is the evidence. And surgical treatment for the non-responders. And hydrocortisone may be particularly beneficial if if it is at a catecholamine resistant hypotension. So otherwise in babies with this Evans et al, the author, they have studied and they have showed the babies in PDA with low systemic blood flow. the would treat with low volume expansion and dopamine starting at 10 microgram per kg per minute. But Mr. The author here, Evans, he's saying that regardless of the BP, so there are, this is the flow based study he has done. So he's saying regardless of the BP, mean BP, even if the mean BP, like we have to give dopamine if there is low systemic blood flow, regardless of the mean BP. And if he is seeing if the mean BP still stays low after addition of dopamine, add dopamine at 5 microgram per kg per minute, which is a low dose, and titrate to acceptable minimum mean BP. So this is for the PDA. So basically for the PDA, early closure of the HSPDA, and if there is dopamine, if low cardiac output state, and dopamine if low mean BP. For the NEC, so NEC, what plays role in the NEC? Hypovolemia and in cardiac dysfunction will be there. So for NEC, it is just like sepsis, SIRS. So typically volume replacement, first line in first line intervention. So for the NEC, vasopressin uses a different receptor to catecholamine, and it might be preferable. So in NEC, there is a evidence that instead of other catecholamines, vasopressin can be beneficial. And also, as the adult study, norepinephrine can have enterocyte more damage to the enterocytes. So in case of NEC, we have to take care of the preload myocardial dysfunction. So for the preload, we may need to give fluid expansion and myocardial dysfunction. So for the coming to the, like any disease causing poor myocardial contractility without vasodilation, dobutamine should be the preferable one. So this is as per one study. And when the myocardial systolic myocardial dysfunction and peripheral vasodilation are present concomitantly, both together are there, like patients with septic shock, medication with both inotropic property and vasopressor effect should be used, like a dopamine or epinephrine is more appropriate. So for septic shock, if you ask what is the evidence, so septic shock, the evidence is more towards dopamine or epinephrine. If there is management of high afterload, so there are two approaches: improving the heart relaxation, lucitrophy, and reducing the afterload. And other thing is improving the contractility. So actually, we want to decrease the afterload, and we want to improve the heart relaxation, and that is a much more effective way of managing patient with high afterload and with cardiovascular compromise. So milrinone has the lucitrophic effect, and it also has myocardial contractility effect in the more mature infants. So milrinone also can cause vasodilation. So it is a good candidate for managing postnatal myocardial maladaptation. So, however, RCT is evaluating milrinone versus placebo in preventing low SV flow in extremely preterm babies. There is no beneficial effect. So here, milrinone and dobutamine. So milrinone is definitely useful as per its properties, but in the RCT there was no effect as compared to the placebo. So if we come to the management of low SVR, vasopressors are the drug of choice. So coming to the flow states, so this is as per the I told the Iowa Handbook of Cardiology. So if there is hypovolemic hypo, so it is on the what is the volume status of the baby, what is the pulmonary status of the baby, like what are the pulmonary pressures, and how is the cardiac function, and looking at all these signs, all these clinical things, they have given recommendations. So in hypovolemic hypodynamics, could be because of the perinatal blood loss or hemorrhages or abdominal emergencies. So here low or normal systemic blood flow depending on the volume status. So the blood flow can be like hyperdynamic circulation can be there, and the systemic blood flow can be maintained, or the baby can go to hypotension. So there can be low blood flow also. Here we can see biventricular poor filling is there. So definitely 20 ml per kg of isotonic saline over 5 to 10 minutes, depending on the severity. So up to 20 ml per kg, and if there is blood loss, O negative uncross matched blood can be given. And then after the volume expansion is done, we have to consider the inotropes. So inotropes can be they should work on the splanchnic circulation to divert the blood from the splanchnic circulation to the mean so other blood so in this case this epinephrine has been used. So if there is low systemic blood flow, so what is the how we will manage? So it is common in very preterm babies in the less than 12 hours of life. Any baby with high ventilation, oxygen need or asphyxia. So low blood flow can be there, as we had discussed. The very preterm babies, they can have low blood flow states in the first 12 hours of life. So the BP can be low or normal. So the main thing is low systemic blood flow. So we have to, there could be poor myocardial function, may be apparent or not apparent. Here again, fluid bolus, but it is 10 ml per kg and slow. And we have to start with dobutamine because they have recommended dobutamine because it's a low systemic blood flow state. And if the systemic blood flow is still not improving, we can increase to 20 mics after starting at 10 mics. And if the blood pressure remains low, add dobutamine and then cardiac screening. So if there is vasodilatory hemodynamics like in septic shock, so it could be sepsis or any baby after 24 hours of life, then recovery from shock or asphyxia. Here the BP can be low because the systemic vascular resistance is low and other variable signs can be there. And uh, it is normal to high systemic blood flow and low BP. So there can, if there is good myocardial function or well-filled ventricles. So also there can be myocardial dysfunction along with vasodilatory hemodynamics, but we are specifically talking about the vasodilatory status. So the here the systemic vascular resistance is low along with good myocardial function. So for this states, if the baby is in early postnatal preterm baby, then we can observe according to them if the other vital signs and are there and babies other signs are good. So no acidosis, no lactates are high and all those things. So here we can wait. So there is vasodilation, there is low BP maybe in the first few hours of life in the preterm baby. Here we can allow for the permissive hypertension and watch and monitor the baby for signs of like progression of shock. So permissive hypertension can be allowed here according to them. Otherwise, if there is signs of hemodynamic compromise, then we have to give 10 ml per kg bolus over 30 minutes. And if it is a septic shock, we can consider more. At the same time, we have to start dopamine. So for the septic shock or the vasodilatory shock, dopamine is the thing and is the agent. And if not improving, we have to increase dopamine the 2 mics up to 15 mics according to them, but safe to be till 10 mics, 12 mics max. And minimal acceptable BP. And if the BP does not improve in the dopamine, then we can add on epinephrine. And later comes epinephrine or norepinephrine, and later comes vasopressin. So if there is normal pulmonary blood flow, PPHN, so like high FiO2 with abnormal signs, BP is normal, then often low blood flow because uh, there can be often systemic blood flow can be low on day one of life, and we have to exclude the CHD, moderate to high PAP pressures. Pressures can be there, bidirectional shunts can be there. Here for the normal pulmonary blood flow PPHN, what they have written is optimize the respiratory things and then consider IONO. And the effect of INO is more variable here because the pulmonary blood flow is normal. So again, if the systemic blood flow is low, then start dobutamine or milrinone and consider isotonic saline. If the blood pressure is low, then consider norepinephrine or epinephrine, but do not consider dopamine over here because there is PPHN. So normal pulmonary blood flow PPHN is there. We can consider INO, and according to the other states of systemic circulation, we have to treat the baby. And if there is no pulmonary blood flow, definitely there is INO to start and follow as per the protocol. If there is because of the low pulmonary blood flow, there can be a low like preload to the left atrium will be less. So here it can lead to a state of low systemic blood flow. So here, if there is low systemic blood flow, start milrinone or dobutamine. So milrinone is preferable, but if there is hypotension, we can start with dobutamine. And if there are also low blood pressures, so then we have to consider norepinephrine, epinephrine, or vasopressin. But there is no role for dopamine over here. So the thing for the INO is, if we are starting INO for the low pulmonary blood pressure, blood flow states, we have to augment the heart. We have to like we have to start dopamine or milrinone, and then we go to epinephrine or epinephrine or vasopressin. But vasopressin and all these are like it is stepwise, like not responding, then we go to those medicines, but there is no role for dopamine over here. So this is if we see the American College of Critical Care Medicine, it has given therapeutic endpoint based management for shock in delivery room and in NICU. So like in adults, therapeutic endpoint based aims are given, and as per that the baby is managed in adults. So there are given according also by the American College of Critical Care Medicine. So here we see therapeutic endpoints given are: at the end of first hour of resuscitation, CRT less than 2 seconds, normal and equal central peripheral pulses, warm extremities, urine output should be good, normal mental status, normal BP for age, normal glucose and calcium concentrations. So if we see here septic shock, and so actually here it is the uh, flow based 2D echo based management. So systemic venous oxygen saturation more than 70% is the target. Cardiac index is 3.6 to 6 liters, and SVC flow more than 40 ml per kg per minute. So this is based on the 2D echo parameters. So here again it will depend on the baby's status, and then the treatment will be there. So there are different approaches: BP approach, flow approach, and even the 2D echo based specific parameters are followed. So if we talk about the inotropes for preterm infants, we are using the inotropes since many decades. So are we any wiser for it? So there are no uniform guidelines for the, especially for the preterm babies, and current evidence only permits some low BP. Only short-term outcomes are there. So basically, what is needed is, it remains unclear. Like we don't have enough evidence in especially preterm babies, and we need more evidence and more RCTs in this field. So coming to the summary, permissive hypotension in the first few days of life in preterm babies is controversial, but still, if it is like isolated hypotension, baby can be observed. Bedside echo is the most valuable thing, which it is in our hands, and in the bedside we can use it for the management of neonatal hypotension. So there are different approaches, but we have to use a composite assessment of the baby, and judicious volume expansion, especially in the preterm babies. Dopamine is the most used, most found safe units, and it is used especially for the septic shock. And dopamine inhibits TSH production. Uh, Adrenaline and norepinephrine are the second line agents, and vasopressin can be the third. Dobutamine increases cardiac output, but it causes decrease in the SVR, so it does not increase the BP, but it is very much useful in cases of myocardial dysfunction. And if we look at the cerebral blood flow, this is a very important parameter we want to look when we are managing any baby with hypotension. We want to be sure that the cerebral perfusion is maintained. So dopamine and epinephrine both can improve the cerebral oxygenation. So and then norepinephrine, it has both beneficial effects on the SVR and the peripheral pulmonary vascular resistance. So it has an effect in vasodilatory shock as well as in pulmonary hypertension. And similarly, norepinephrine, vasopressin for refractory vasodilatory shock and in pulmonary high PVR. And hydrocortisone, definitely we know the steroids, they are definitely useful. They decrease, they help in weaning of the inotropes. So milrinone in the post-cardiac surgery patients, and hydrocortisone, it is as effective as dopamine, reduces need for vasopressors, and useful in HIU also. And in septic shock, especially in the early onset sepsis, INO can be useful if it is associated with PPHN. But in late onset sepsis, with INO, it is more of a hyperdynamic pulmonary hypertension. So there we have to be do a 2D echo, assess the baby, and then use INO very carefully. So these are my references. Thank you. So any questions are there? Please put in the chat box. In ELBWs with immature skin, how do you routinely assess perfusion? SCRT is not much reliable. How to prevent injury due to BP cups? Yeah. So while I was going through the evidence for the this how much are the clinical sense reliable in the babies. So CRT has been shown it is not, we do routinely assess perfusion as CRT, but the studies have shown that if the CRT is as long as 4 to 5 seconds or less than 2 seconds, and if we compare, is it showing the state of the baby's hemodynamic state? So they have shown that CRT is not at all reliable as per a study, but I can't exactly tell which study, but I had went through the literature, so I could find that CRT is not at all reliable as per the study. But in clinical practice, we do find that CRT is good. And how do we prevent injury due to BP cuffs? So here, what we are doing is we tie a gauze piece, and over that we are putting the BP cuffs, and we are removing the BP cuffs timely, and then putting again only when the BP is going to be measured. In ELBW or any baby with perfusion abnormality, it requires overall assessment of hemodynamic, that is temperature, sensorium, urine output, heart rate, NIBP, IBP, functional echo lactic acidosis on ABG. CRT alone may not be reliable to give overall picture, right? Correct. BP cuff positions need to be changed every few hours to prevent skin damage in elbow. Plus, use tegaderm before applying the cuff. Yeah, this is we need to change and remove the. So role of norepinephrine when compared to dopamine in vasodilatory shock, septic shock, as dopamine aggravates more pulmonary hypertension when compared to norepinephrine. Role of norepinephrine in vasodilatory shock in PPHN. Okay, so definitely when we are dealing with septic shock, so in the late onset septic shock, what we find that pulmonary hypertension is really not very common. Only in the early stages, early onset septic shock, the pulmonary hypertension can be significant. So in the late onset septic shock, as the PPHN is more of hyperdynamic, more flow to the lungs. So role of the dopamine really doesn't have a disadvantage in late onset sepsis or vasodilatory shock with normal pulmonary blood flow. So if it is only less pulmonary blood flow like in early onset sepsis, then the literature is showing that then at that time dopamine should be avoided, and then other drugs like for the hypotensive agents like epinephrine, norepinephrine can be used. So I think I explained the point. Late onset sepsis has less of low pulmonary blood flows. So dopamine is useful over there. But in early onset, where the pulmonary blood flows are low, there dopamine should be avoided. So we should do a clinical assessment. We should go for a 2D echo bedside. We should look at the pulmonary pressures for the tear jet. All those things we have to look at. And if there is a component of pulmonary hypertension, then we should definitely avoid dopamine, and we should go for norepinephrine, epinephrine as for the low BPs. Any more questions? So if anybody wants to unmute themselves and talk, we can discuss over here. Today, Dr. Nalinikan sir, he was traveling, so he could not moderate the session. So I think there are no more questions. So we can close the. I'll close the presentation. Stop the sharing. Thank you all.